Hello, I'm Dr. Summer McGee, and this week we will be covering Chapter 6 in Introduction to the U.S. Healthcare System. And this week we will be focusing on healthcare finance and the role of various kinds of health insurance programs have on the payment and the delivery of healthcare services in the United States, and really how changes in health policy, and in particular changes in the Affordable Care Act, have dramatically been changing how healthcare finance also works in the United States. We're going to cover some basic terminology about health insurance to make sure everybody understands all the different concepts that exist in the health insurance world, as well as looking at some trends, both in the private employer-based health insurance market, trends in the public insurance program market, and also looking at how reimbursement is changing and some of those emerging trends that are also resulting from the Affordable Care Act. We're also going to explore how the national healthcare expenditure picture is changing. As you know, in the U.S. healthcare system, we do not have a global budget for healthcare because it is financed in such a large part by the private sector, where spending is not controlled at a global level. So we're going to look at some projections to understand about where healthcare finance and healthcare expenditures is going or likely to go as a result of some changes in the Affordable Care Act. So first, let's start with an introduction to healthcare finance. As is true in many other parts of the U.S. healthcare system, one of the hallmarks of healthcare finance in the United States is its complexity. There are a wide range of private plans from a handful of large corporations who offer these plans. We're going to talk about all the different ways in which the health insurance plans that are available in the private market are different. And that you really have to be a very savvy consumer and really understand the nuances of these plans to be able to make informed choices. What we also know is that there are many government programs that pay for the delivery of health care, as well as many different methods by which that payment is secured by healthcare organizations and others. We will also talk about why and how some people lost health insurance under the Affordable Care Act, as well as how the federal government is going to facilitate new people, many more people, purchasing health insurance thanks to the Affordable Care Act. As always, we're going to talk about why managers need to understand healthcare finance. If you are maybe somebody who's working in a more clinical side or working in human resources, you may say, I don't really need to understand all these aspects of health policy, all these nuances of healthcare payment and delivery. And what I would say to you is that healthcare finance is essential to understand for all people working in healthcare, because at its most basic level, it is how this industry and the businesses that you work for remain operational. This is the method by which money comes in the door to pay the salaries of the people you manage, to pay for all of the buildings and the equipment and all of the things that you see around you. And so you need to have an understanding about how healthcare finance works, how healthcare finance is changing, particularly in the Affordable Care Act context. And so it's really important to understand all the different ways in which money flows in the U.S. healthcare system, because the healthcare organizations in which you work and which you work for are the direct recipients in many cases of those funds. So the first thing to understand is that, of course, there is financing that is needed to pay health insurance premiums. That financing either comes from employers, or it comes from individuals, or it comes from taxpayer dollars in the case of public systems. Health insurance in the United States is the primary mechanism by which people obtain healthcare services, whether we're talking about the private market or the public market. Health insurance is the vehicle, it is the ticket by which you get access to healthcare delivery in the United States. It is not guaranteed, it is something you have to pay to play. Financing influences the supply of healthcare. Now, what does this mean? Now, how healthcare is paid for influences how much healthcare there is out there to purchase. healthcare services, capital expenditures, renovations, how much money there is in the system, how much money healthcare organizations can collect, either from private insurance companies or from the public sector, determines how much healthcare an organization can deliver, because the limiting factor is, of course, the money. What we see as healthcare finance and healthcare policy related to finance is changing, we see that new models of healthcare organizations are likely to form. And this is where we see changes like the patient-centered medical home model, different ways of providing care to maximize the level of reimbursement that organizations are likely to receive. And so it's important for managers to understand that healthcare finance and healthcare policy finance is one of the biggest drivers of how healthcare organizations function operationally and how they deliver care. So the dollars drive the decision making. Supply and distribution of healthcare is significantly affected by these kinds of changes. So as a healthcare manager, it is vital to understand that as people have access to health insurance, and this is particularly true in the context of the Affordable Care Act, as people have access to health insurance, they are more likely to then utilize healthcare services. In other words, this drives up demand. There is more demand for healthcare services. Insurance also lowers your out-of-pocket costs. It buffers the financial risk that the consumer would have otherwise had if they did not have insurance. Part of the entire basis or rationale behind having health insurance in the system is that it buffers or reduces the amount of financial exposure that any one individual is likely to have for utilizing healthcare services. That's a good thing because most of us could not afford to pay the full freight, the full expense of most healthcare services we utilize. The health insurance companies help us mitigate that cost. The risk, of course, of that scenario is that often patients consume more healthcare than they need. This is a concept that we call moral hazard. Because you don't feel the full financial impact of the healthcare decisions you make, because you don't pay the full $10,000 or $12,000 for that CAT scan, because your health insurance is covering everything except for your copay for that particular transaction, you may be more inclined to say, well, yeah, I want those blood tests, I want that CAT scan, I want all these medications, because I'm only paying a very small portion of the actual real cost. So that is a concern. Moral hazard is a real concern in the health insurance industry. And we've seen that, in fact, moral hazard has resulted in higher than is justified healthcare consumption on the part of consumers. And that's why we see a real pushback and an increased level of cost sharing on the part of consumers to try to disincentivize non-necessary medical expenditure. The effect on total healthcare expenditures is really major. So what we see is that the role of health finance and how healthcare is financed and how health insurance is financed, in particular, the percentage of cost sharing we see has a big impact on the total expenditures that are being made, not just for an individual, but at a global level in terms of the entire country. Even though we know that the Affordable Care Act has resulted in 8 or 9 million more people having access to health insurance, many people still do not choose to purchase health insurance. And they often come to hospitals, particularly safety net hospitals or public hospitals, to access and utilize healthcare services in those cases where patients cannot pay. Or sometimes even if you have insurance, but there are significant expenditures that are not covered. What we will see is that hospitals then have to provide what we call charity care, care that will never be reimbursed either by health insurance or be able to be paid for by the consumer. And that is still going to be a big part of the U.S. healthcare system for some time to come. Now, Here, if you look at this chart, what you see is the average annual growth rate, the average percent by which the United States global health expenditure, the total health expenditure budget, has been increasing. Part of the reason why in the 1970s, President Nixon called for a national health insurance system and moving for a health maintenance organization or HMO model is because in the 1970s we saw an average annual growth rate in healthcare expenditures of 12%. This was huge, right? Huge amounts of medical inflation, huge amounts of technological advance, which resulted in significant costs for consumers as well as hospitals. We also saw these trends continuing through the 1980s and the 1990s. Even well into the early 2000s, the annual rate of growth of the global U.S. health budget was somewhere between 6 to 8%. Now, there's this period of time where the annual growth rate of U.S. healthcare spending dropped significantly down into the 2 and 3% rate. And I will actually challenge you to think about why the annual growth projections, the annual growth rate in spending actually dropped significantly during this period of time. If you think about what was going on in the United States from 2008 through 2013, I'm guessing you can probably guess why healthcare expenditures, they were still growing, but they were growing at a much slower rate. Now, what we see here going forward as we project out into the future is that we expect a somewhat more significant rise in terms of healthcare expenditures from what we've been spending in the United States. But hopefully there's a sort of a leveling off effect of about a 5% annual growth rate in the healthcare industry. So think about what drivers, what events have happened in the United States that probably is the cause of this chart. And this is something that I want you to talk about in the discussion board because I think it's really important to understand that a lot of what's happening in the U.S. healthcare system is not isolated just to healthcare policy, but it can also be influenced by other social, political, and economic factors. And also think about why you think that there's likely to be this big jump in 2014 going forward, but then sort of this leveling off of healthcare expense. Health services financing, or what we also call health insurance. Health insurance is the way that we pay for healthcare in the United States. It's how we pay hospitals, it's how we pay physicians, it's how the financial transaction takes place between the provider and the receiver of care. There always is an intermediary. We call this a third-party administrator. We typically think of this as a health insurance company. The health insurance as an entity determines what kind of access you have to certain kinds of providers or procedures. It determines the demand or how much utilization you're likely to have of healthcare services. We've already talked a little bit about the fact that it results in moral hazard because you don't feel the full weight or impact financially of the choices you're making because the health insurance is covering part of that expense. What we also see is that it influences the supply of healthcare services. Providers and hospitals and other healthcare organizations say, if insurance covers it, we're going to offer it because we know that it's something that we will, if we do it, we're going to get paid for doing it, right? If there are things that health insurance doesn't offer, doesn't cover, the supply of those procedures is going to be dramatically reduced and subject to simply whether people are willing to pay out of pocket for those kinds of services. It can also influence supply and demand for healthcare professionals. So if health insurance companies begin reimbursing for certain kinds of care, such as complementary and alternative medicine, that will result in a significant amount of demand for those providers to exist in healthcare organizations, and it will result in increased supply of those services to consumers or patients. Ultimately, what health insurance covers and provides for directly influences the total healthcare expenditures or the total cost of healthcare in the United States. It impacts costs because they ultimately set the prices that they are willing to pay for the procedures and services that providers provide. And ultimately, if health insurance companies do not cover or do not provide reimbursement for certain kinds of procedures or certain kinds of things, they can impact the overall healthcare budget because certain things are not going to be covered for at all or at a certain level. So ultimately, how much and what health insurance pays for determines the global healthcare expenditure in the United States. Now, this is how health insurance companies ultimately engage in cost control. Expenditures can be increased by expanding health insurance, either in terms of access to health insurance or expanding health insurance in terms of the procedures and institutions or providers that are covered. They can also increase expenditure in the U.S. healthcare system because expenditures also includes the amount that consumers or patients pay in health insurance premium. So raising the amount of health insurance premium also results in a global increase in the total health expenditure for the United States. We also see that expenditures can be reduced by restricting who can access health insurance, by restricting eligibility, and therefore by reducing demand for healthcare services because fewer people will be able to pay for them. Restricting reimbursement to providers, paying less for certain kinds of procedures, not paying for certain procedures at all, that reduces overall expenditures. Having fewer specialists, not covering or including as broad of a network of specialists, and leaving those kinds of services, certain kinds of elective specialist procedures like plastic surgery, leaving that for consumers to pay for. If certain kinds of things were covered by health insurance, let's say Botox, if that was something that was covered by health insurance that could be reimbursed, our global health expenditure budget in the United States would probably go up by 5 or 10% because everybody would want to have access to Botox, for example. And what you would see is that more and more people, maybe who might not have gotten it in the past, because they had to pay the full cost of those kinds of elective cosmetic procedures, you would see moral hazard coming into play because now they don't feel the full weight financially of those expenditures and are likely to get them because they don't cost them so much out of pocket. Expenditures can also be reduced by spending less on research and development. It can also be done by controlling use or utilization, so limiting the number of, for example, in mental health care or psychiatric care. What health insurance companies do is that they only pay for a certain number of visits per year. So you need to look very carefully at your mental health benefit coverage because it may say that you are eligible for X number of visits per month or X number of visits per year. And that's how they cap utilization by saying we will only allow certain kinds of healthcare services to be done so frequently. You see this also not just in health insurance, but also in dental insurance. They cap utilization of things like x-rays by saying you can only have a set of x-rays done once a year that health insurance will pay for. And so they put control on that utilization on the part of providers by telling consumers that they won't pay for those services. They also designate certain services as non-covered. So certain kinds of procedures will not be covered by insurance at all. So who's paying? Who are the financiers of health services? Well, obviously employers provide a significant amount of private financing. Employers either use third-party administrators, companies like Blue Cross Blue Shield or Aetna or United Healthcare, to provide the health insurance benefit to their employees, or employers can choose to be self-insured, which means that they will directly pay for the health care delivery costs of their employees. They act as their own health insurance company. So they provide access to providers and access to health insurance directly as a benefit to those consumers. And they basically operate their own company-specific health insurance plans. So you can either be self-insured and pay for all those costs, or you can use a third party, typically a health insurance company, to help administer the health care services and delivery for your company. The other financier of health services, the other big one, of course, is the government. The government provides public financing for healthcare services provided through Medicare and Medicaid, and we're going to talk about those in much greater detail later on in these lectures. Or the other financiers are you and me, individuals who self-finance. We self-finance health services in the United States through our copays, through our coinsurance, and through our deductibles, and we're going to talk more about those terms in a few minutes. What we see in terms of finance and cost control is that because insurance really dictates the level of demand, how much healthcare we can use and want to use, it means that if you then restrict what will be paid for by health insurance, it automatically reduces access and therefore expenditures. So you see here this ratio that explains how health insurance engages in cost control, basically by saying that there is a price or a payment that is times the amount of utilization that results in overall expenditure. So what you see here is that if you can control utilization, if you can control either supply or demand, you can really reduce Q. If you also put certain restrictions on P, if you only pay a certain amount, health insurance can control the overall global expenditure that they are paying for health care in the United States by impacting either P or Q. What we see is that, of course, there are other external factors that affect P and Q, such as medical inflation, the amount that just healthcare costs and expenses go up because of advances in technology and other economic factors. You can also see that there are other things that affect costs, such as the size and demographic changes of a population. If the population of the United States were to increase by 1 million people, while you could do certain kinds of things to engage in cost control, you just know that the overall total health expenditures for the nation is going to go up. We see this happening as a result of the Affordable Care Act. We see that the total health expenditures in the United States is, of course, going to increase dramatically because the number of people eligible to be expending healthcare resources in the United States is also going up. So what is health insurance really? I think health insurance is a really complicated concept for a lot of people. But what I want to do is show you a really short video that kind of explains the concepts on this slide, and I think does so in a very effective way. So if you have any questions about health insurance after this video, we can definitely talk about it in class as well.
At Best Buy, our experts in the Samsung Experience Shop can help you get the most from the new Samsung Galaxy S6 Edge Plus. It has a big, bright screen that fits easily in one hand, and wireless charging capabilities get you back on the go. Plus, it has built-in live broadcasting, so you can share the moment while you're in the moment. The Samsung Galaxy S6 Edge Plus has arrived. Expert service, unbeatable price. Best Buy.
Hi, I'm Dr. Aaron Carroll, and welcome back to Healthcare Triage. We're going to be doing this show every week now, so make sure you subscribe right down there. In the first episode, we talked a lot about Obamacare and how people without insurance were going to try to start getting it. But that led to a lot of questions about insurance in general.
Yeah, exactly. When am I going to stop having to pay for my insurance?
You're still going to have to pay for your insurance. Obamacare is about access.
Now, Aaron, this was supposed to be a big government giveaway to friends of Obama. I am friends with Obama. I don't understand what went wrong.
Nothing went wrong. Let's start this week with the basics of health insurance. How does it work? How much is it going to cost? We're going to answer that and more in this episode of Healthcare Triage. Comprehensive health insurance isn't as old as you think. The first real plans appeared in the U.S. around the time of the Civil War, and really those were just types of accident insurance in case you got injured while traveling on a train or a steamboat. This wasn't nothing, since trains and steamboats exploded pretty regularly in those days, but it didn't do much to help with what we would all consider routine health care. Well into the 20th century, there just wasn't that much need for health insurance. After all, what would you do with it? There wasn't much health care to buy. If you got sick, it wasn't like there was an MRI scanner or artificial heart that you were going to get. You went to the doctor for leeches and laudanum, but if you got really sick, well, you sort of died. But as doctors and hospitals learned how to do more than amputate legs and shake their heads wistfully, they realized there was real money in this gig. So in 1929, a bunch of them joined up and formed an insurance plan called Blue Cross to help people buy their services. Doctors didn't like the idea of hospitals being in charge, so they created their own plan in 1939, which they called Blue Shield. So you had your Blue Cross for hospital services and your Blue Shield for physician services until they merged to form Blue Cross and Blue Shield in 1982. For the most part, people bought health insurance on their own if they wanted it. Some jobs offered it, but employer-sponsored insurance wasn't really a thing until World War II. Wartime emergency plans put wage controls in place, and so by law, companies couldn't compete for workers by paying them more. With so many men fighting overseas, employees were relatively scarce. So employers started competing for workers by offering them benefits like health insurance. Those weren't restricted by wage controls, and soon lots of jobs were paying for more and more comprehensive coverage. After World War II, President Harry Truman proposed scrapping this system for one of universal public health insurance. People loved this idea, but doctors, hospitals, and many businesses hated it. They'd already invested quite a bit in the current system. Labor unions also realized that they had a lot to gain by keeping insurance tied to jobs. They'd fought hard to get benefits for their members, and changing to a national insurance system would have made these gains moot. Truman lost. Employer-based health insurance won. Over the next 20 years, private insurance increased in popularity, but remained mostly unavailable to the elderly, the poor, and the unemployed. No one wanted to cover seniors, because they get sick a lot and cost a ton of money. But this meant that more and more people were faced with the difficult decision of going broke or letting their parents die. This was intolerable to many Americans, because all of them expected to be old one day, and they had no interest being stuck in this dilemma. After years of fighting, President Johnson signed Medicare and Medicaid into law to cover the elderly and the poor, and today government programs cover about 1/3 of Americans. The rest of the insured are covered by private insurance. But why do we even need insurance? To put it simply, healthcare is very, very expensive. My oldest son had to go to the emergency department about a month ago. He received just an ultrasound and a doctor read it. Turns out he was fine, and he just needed an antibiotic. The cost of that visit, $6,000. And that's cheap compared to really big things like a hospital stay. Last year we spent something like $2.7 trillion on healthcare. That's upwards of 18% of our GDP. Most people don't have the kind of money to pay for care if they get sick. That's where insurance comes in. Everyone individually pays less, but sick people get the money. We pool risk, and the money goes to whoever needs it. By the way, anyone that complains that they don't like paying for someone else's health care is completely missing the point. Insurance is always about paying for someone else's health care. It transfers money from the healthy to the sick. How does insurance work? Well, the first thing you do is pick a plan. Plans differ on the amount of actuarial value they have. That's a fancy term for describing the approximate percentage of the cost of care that insurance will cover. If a plan has 60% actuarial value, then it covers 60% of the cost, and you cover 40%. Plans with higher actuarial value cost more. You pay more up front and pay less later. In the insurance exchanges, which we talked about in our last video, bronze plans have a 60% actuarial value, silver plans are 70%, and gold plans are 80%. Insurance also has networks of physicians. These are doctors or hospitals with whom the companies have negotiated lower rates. You get better coverage if you stay in network, and pay more if you go out of network. So if there are certain doctors you really want to see, you need to make sure they're part of your plan. The money you pay up front is called a premium. That's often charged monthly. That's what you see when you find out how much a plan costs. But that is not all the spending you'll do. Pretty much every plan comes with a deductible. This is an amount of money that you're responsible for paying even after the premiums, before insurance coverage kicks in. The reason plans use this is that they think correctly that you're less likely to spend your money than their money. It prevents you from going out and getting a ton of care that you might not need. More expensive plans, which have more upfront money, usually have lower deductibles. Less expensive plans have higher deductibles. Not all care is subject to the deductible. For instance, most preventive care is fully paid for by your insurance right away. Even after you spend the deductible, you're not done. Most plans come with co-pays. These are set fees that you have to pay each time you access the healthcare system. They may be $20 for a doctor's visit or $100 for an emergency department visit. And it gets better. There's also co-insurance. It's the amount that you yourself have to pay for care above what your insurance pays. And then you have to give them a firstborn child, 2 wishes, and an ounce of ground unicorn horn. Just kidding. It's actually only 1 wish. Okay, I'm kidding about the whole thing. It's just the co-insurance is weird. It's not all bad. Plans now come with an annual out-of-pocket maximum. For a family, it's at most $12,700. And for an individual, it's $6,350. So after you've paid that amount in deductibles, co-pays, and co-insurance, you're done. It's all on the insurance after that. Even better, there are no longer any annual or lifetime limits. Your insurance can never run out. So if you bought a silver plan, say with an actuarial value of 70%, for yourself from the exchange in Indiana, the premium might be around $4,000 a year, or just over $350 a month. Let's say it has a $1,500 deductible, $20 in co-pays for doctor visits, and 15% co-insurance. When the year starts, even with the insurance, you'd be paying for almost everything until you spent the $1,500. Then you'd be paying $20 for each visit plus 15% of other charges until you hit $6,350. In a bad year, you could be on the hook for a total of about $10 grand, or the cost of the premium plus the maximum out-of-pocket expenses. This is going to come as a shock to people who assume that health insurance would now be cheap or even free. But you have to look at what might have happened without it. What if it had been you who had to go to the emergency department a month ago? Instead of costing you $6,000, under this plan, you would have been responsible for a $350 copay and $900 co-insurance payment. That $1,250 is much less than $6,000. And this could happen a couple times a year. Or you could get really sick. Or you could have a kid. The average price for having a baby in the United States is $30,000. If you have a cesarean section, it's $50,000. People with insurance are way, way, way better off than those without it. So do your research. Figure out what you're willing to pay up front in premiums, but don't forget that networks, deductibles, co-pays, and co-insurance matter too. Figure out if you'd rather pay more up front or gamble that you won't need to and pay more later. But make an informed decision. Now you know. And knowing is half the battle. I always wanted to say that. Go, Joe.
So hopefully that video made clear many of the concepts about health insurance.